I welcome you to all for this session. Our session is named Clear Vision Ahead, Keys to Effective Refraction and Spectacle Prescription. So spectacle prescription being, or spectacles or refraction being the bread and butter of every ophthalmologist, we need to know all the details about this spectacle prescription, but it is very less dealt in most of the situations. So we would like to give some informations regarding this. And so without we'll be conducting the session in five segments, and we'll initiate the session with Dr. Ruxana, who will be dealing with pediatric refraction. So I would like to inform you all that we'll have the discussion at the end of all the sessions. Thank you. Dr. Ruxana, please.
Good morning to all. Today I will be talking on pediatric refraction. As we all know, refractive error is the most common cause of visual impairment in 60 to 80% of the children. And early detection and management of refractive error helps to achieve optimal acuity, binocularity, and overall development of the child. Inappropriate refractive correction will hamper the child's optical and neural development. The challenges that we usually face in pediatric refraction is because of the limited cooperation, low reliability, and because of the children have greater range of accommodation, difficulty in quantifying the visual status, and because of the risk of amblyopia. So, objective refraction is preferred than subjective due to this limited reliability and strong accommodation of the child. So, how to assess refraction? Visual assessment is usually age appropriate. Less than 2.5 years of age, you usually assess with fixation and following of movement or with light. Preferential looking charts like Cardiff cards can be used. And objection to occlusion and fixation preferences also is used to assess the refraction. And 2.5 to 4 years of age, symbols or alphabet matching cards like Allen's card, HOTV, and Leah symbols can be used. Above 4 years, Snellen or Logmar chart can be used. Pediatric refraction assessment is not complete without the complete eye examination, and hence it's mandatory. And it includes Hirschberg test, cover-uncover test, EOM assessment, convergence, complete squint examination if detected. Anterior segment examination, fundus examination with objective refractive method like retinoscopy is mandatory. Now the indications of cycloplegic retinoscopy. It is indicated in every non-verbal child, young patient with symptoms but no refractive error, young children, those with strabismus, and those child with accommodative asthenopias, and those we suspect pseudomyopia or latent hyperopia, and when there is a poor reliability between the objective retinoscopy and subjective. So cycloplegics, as we all know, the mainly used cycloplegic in children is atropine, homatropine, cyclopentolate. Cyclopentolate 1% is preferred routine use in children, and cyclopentolate 0.2 to 0.5% can be used in infants. In some ophthalmologists use atropine 1% for younger children with ESO, and because of the many side effects and prolonged blurring, it should be used only in these children with ESO. A regimen that is commonly used that have comparable cycloplegia as atropine 1% is a CTC regimen. That is cyclopentolate 1% instilled twice, followed by tropicamide 0.8% with phenylephrine 5%, 5 minutes apart. And the retinoscopy can be performed 45 minutes after the first drop instillation. As we all know, cycloplegic have a number of side effects, and it should be always avoided in children. Overdose of cycloplegic agent should be always avoided in children with Downs, cerebral palsy, trisomy 13-18, and CNS disorder, as it can be hallucinogenic. The American Association of Pediatric Ophthalmology and Strabismus has guidelines for prescription of glasses, and they have classified the children according to the age, and the diopters beyond which the glass should be prescribed is considered depending upon the refractive error of the child. And there is also a national consensus for the minimum refractive correction to be prescribed in infants and young children. We'll be dealing with it in the coming section. So the gold standard is always objective refraction using retinoscopy. Prior to the glass prescription, we know the refractive status of the child is constantly changing with age. Hypermetropia should be always corrected early than myopia because the children are usually into near activities. Child less than 2 years, minimal myopia, there is no need of any correction. Risk of amblyopia depend on the magnitude and type of refractive error as well as the age. And anisometropy is the most common cause of the amblyopia. Cycloplegic refraction and in associated strabismus should also be considered before prescription of glass. Then each refractive error per se, hypermetropia, it should be corrected earlier. And more than 5 diopter, usually the child can present with asthenopia. So if uncorrected, refractive accommodative ESO and amblyopia can develop. In infants less than 6 diopter, usually there is no correction given according to the American Association of Pediatric Ophthalmology and Strabismus guidelines. In children with no ESO, mild undercorrection can be given. ESO with high AZ by A ratio, full cycloplegic correction with bifocals is mandatory. Myopia, less than 4 diopter, no correction is required in infants. But 3 to 4 years of age, you should prescribe even for lower degree of myopia. You should always avoid overcorrection and prescribe lowest minus powers. In presence of intermittent exo, even the smallest myopic correction is prescribed. In astigmatism, it's not overcome by accommodation. Hence, power of more than 1.5 diopter to 2 diopter can be amblyogenic and it should be prescribed. Children usually accept high cylinders more easily. So spectacle fittings and centration is very important in high cylindrical powers. Anisometropia. Hypermetropic anisometropia and cylindrical anisometropia are more amblyogenic. A difference of more than 1.5 hyperopia or astigmatism need to be corrected. But in myopia, a difference of more than 3 diopter needs correction. If amblyopia is already present, amblyopic treatment is mandatory. In aphakics and pseudophakic, overcorrection by 2 to 3 diopter is recommended as a child is more into near activity. By 1 year post-op, you have to reduce the overcorrection by 1 to 1.5 diopter, and by 2 to 3 year post-op, bifocals can be considered. Okay, thank you.
Thank you, Dr. Roxana. So there is a slight rearrangement in the schedule. We'll be moving on to the next topic by Dr. Thomas Alan Varghese, that is all about spectacles. Over to you, sir.
Good morning, everyone. At the outset, I'd like to thank Dr. Anjana, Dr. Sanitha, and KSOS for this opportunity. This is a topic that we don't really speak much about. We leave it to the opticians. But I think increasingly, this is something that we need to look into because very often, if the patient is unhappy, they come back to us. So all about spectacles, whatever I can in 9 minutes. So of course, certain things that we have to play an important role is a detailed history and symptoms. The occupation of the patient, their working distance, I think they're extremely important. And we should make sure of that before we're giving our prescription. And the range of clear vision that they would like to have. IPD, these fancy gadgets are there to measure IPD now. And of course, for any prescription beyond 5 diopters, +5 or -5, it is important to record the back vertex distance. And make sure when you write the cylinder, it is the same power in both, same sign in both eyes, and also the axis. So selection of frames, really patients are now spoiled for choice for the selection of frames and lenses. Most important things, of course, comfort and fit of the specs, frame material, lens compatibility, durability and flexibility, aesthetic appeal. Increasingly, our patients are all very concerned and pay a lot of attention to the aesthetic appeal, adjustability and maintenance, and environmental resistance. Some frames, some materials, as you know, can get damaged by sweat and other other water. And during the COVID epidemic, a lot of people had problems because of sanitizer use as well. So some things that we can pay attention to, and some probably you can just advise the patient as well. But finally, of course, it is their own decision. The style, the personality, face, the shape of the face, the size of the face, all these are important. Nose features, skin and hair color, and type of lenses. And I'll go through this briefly. This picture on the right that you can see is a radio jockey, Nina, whose videos are viral about the new WhatsApp fraud which is coming up, where your WhatsApp account can be hacked. And you can see her fancy glasses. I don't think we can actually wear this to work. So a lot of it depends on the profession and what the patients do. So the professional look versus the casual look. And this center picture you can see is the lady in a new movie, and you can see really fancy glasses there. So the face shape, what they say is that ideally your frame should complement your face. So if you have a round face and you don't want to people to focus too much on that, you can use a slightly square or rectangle frame. And so based on the different face shape, and a lens can be chosen which can sort of complement your face. And I'll show you an example here. So lady on the left, she's got a nice round face and her glasses are also quite round, while the lady on the right, very similar looking glasses, but she's got a very oval face. So it sort of balances out with the face shape as well. The comfort and fit of the spectacles, you can see different parts. The bridge is very important, and the temple length, that is the leg of the frame, that is what is very important. And of course, you want to use a light material and which is strong as well, like titanium or acetate. The nose, very important. Some people, well, majority of people actually a slight bend in the nose, and so some frames just do not sit. The different types of bridges are the keyhole bridge, the saddle bridge, and sometimes if it's a marked deviation in the nose, then ideally you should have a frame with a nose pad which can be adjusted to balance the problem. The width of the frame shouldn't be too wide. Then you have the legs sort of splaying out, or it shouldn't be too narrow. It should be just right, the size of the frame. And patients who are already using spectacles, if you look at these numbers on the frame, they're quite happy with those spectacles and just going for a new one or a power change, then you can look at these numbers on the frame, which will actually tell you the width of the frame. So the two lenses width plus the distance between the lenses, that will give you the width of the frame. And so if they're happy with a particular frame, they can go for the same size frame. Some people also suggested based on the skin tone, you can use different lenses, but finally, as I said, it's a personal decision. So if it's a warm tone skin, go for a gold or brown frame, as opposed to a light, cool tone skin, you go for a silver or blue frame. There's these new gadgets now. We take a photograph, it's called an OpticCam pad, and we just take a photograph and gives all these measurements. So monocular PD, the segment height, pantoscopic tilt, vertex distance, all these can be taken just with the photograph. You can get all these measurements, so it really saves a lot of time. Frame material I already emphasized. So light, strong material, titanium, stainless steel, acetate. And people with tendency for allergy, you can use hypoallergenic materials like titanium, again stainless steel, and high quality plastics. The lens prescription, you have to match with the frame size. So if it's a high prescription, go for a slightly smaller size frame. Otherwise, the lens will be too bulky. Or otherwise, of course, you can go for a high index lens. And multifocal lenses, some people, for style reasons, they go for a very narrow, vertically narrow frame, but then the area you have for the different powers is very much reduced, and they can be very symptomatic. So a progressive, you need to have a minimum height so that it gives adequate area for the different powers. Frame selection, this is something I often have a difficulty with, because when I go to buy new glasses and I try on the new frame, I can't actually see myself in the mirror because my power is -4. So now I bring the mirror really close up to see how I look with the frame. But nowadays you have these gadgets which take photos and show you the wearing with the different lenses, different spectacles and frames, and then you can see how it looks. This is an article my daughter showed me this morning in a very popular magazine, Grahalakshmi. You can see written by Dr. Chandrakant. It just shows how much importance parents give to spectacles worn by their children. So this now I'm just going to briefly talk about children's spectacles. So dispensing lenses, you can see there's so many beautiful frames that are now available. This is a photograph of me in 7th standard. You can see I had this thick frame because I was a hyperactive kid and my parents were very worried that I would break the frame. And my first time I started wearing in 5th standard, and in 6 months I broke 3 frames. So you can see the importance is that the child should be happy with the looks and also the comfort, otherwise they're really just not going to wear it. And the bridge, they say, is that the bridge should ideally be at the middle level so that it is not, because the nose is still developing. So nowadays you have these beautiful frames, very flexible. The child cannot break it even if the child wants to. And also if you want, you can add this strap at the back so that it doesn't slip off. And also at the back you can have, you have this what is called the riding bow, so that the lens spectacles doesn't slip off from the face. Briefly on the various types of lenses. Again, for children, you have ideal lenses are the CR39, poly, MR, and definitely no glass lenses. So here again, you're worried about clarity, lightweight, and good optics. And lens selection, as I said, if it's a high power lens, go for a high index lenses, or else you can go for a slightly smaller size frame. Briefly on the progressives, you can see different new progressives that are now coming out, which are much wider area of clear vision. So these are the conventional progressive addition lenses. Then you have the freeform progressive addition lenses, which gives a much wider area. And now, of course, don't forget the online revolution. And I was just trying this out. This is from Lenskart. It takes your photograph, and then you can try on the different frames and how you look with the different frames. And increasingly, especially our youngsters, are going for online purchase. And of course, if they have a problem, they're going to come back to you. And when you get the spectacle, the patient always asks, Doctor, Kannada vaanchenya kondonnu kaanikano? You just say yes. And then what you can do is, what is this known as the 4-point touch method, where you just put the specs upside down and make sure the 4 points are touching. That means the alignment is correct. And quick adaptation tips. So obviously tell the patient, don't keep switching with your old spectacles and new spectacles. Stick to this for a good few days and use them as the primary pair. And of course, in the case of progressive, just tell them it's going to take 1-2 weeks to get adjusted. Thank you. And that's me in 10th standard, slightly smaller frame. Thank you.
Thank you so much, sir. That was a very elaborate, yet concise presentation, and with your personal touch, it made it more fun. Thank you so much, sir. I welcome Dr. Sanita for her presentation, that is troubleshooting after spectacle prescription. Over to you, madam.
A very good morning to all of you. I'm happy that you have turned up for the first session. And so, how many of you have had a patient who had actually he was a pain in your neck after prescribing spectacles? Can I have a show of hands? Okay, there are a few who are lucky ones, but thank you, Dr. Arun, for setting the background for my talk. Now we'll be talking about troubleshooting after spectacle prescription. So just like we say, once we do a cataract surgery, once we do enough number of cases, all of us will have some complications, we'll have some difficult patients. Like that for if you give a lot of spectacles, however perfect your team may be, however perfect your prescription may be, you will have some patients who are unhappy. So when this patient comes to your office, the first reaction would be, oh my God, he's out of the door and now I'm having a difficult time. And but this person, he has told that your most unhappy customers are your greatest source of learning. So if you are doing a spectacle business, or even as a practitioner also, unhappy patients teach us a lot. So I'll try to share some of the learnings which I have had in running a hospital and being a person who has prescribed a lot of spectacles. So patient will have a lot of complaints. So we'll try to group it as systemic, visual and mechanical. What are the systemic complaints? Headache, we know കണ്ണട വെച്ചിട്ട് ഭയങ്കര തലവേദനയാണ്. വേർ ഇസ് ദ തലവേദന? ഇറ്റ് ക്യാൻ ബി എനിവർ, പെരി ഓർബിറ്റൽ, frontal, even occipital, temporal. The whole head don't think that the patient is lying. It can produce such a difficult symptom also. And they might have dizziness, nausea, fatigue, and even a burning sensation. And what are the visual complaints? Mostly they will say that they have a blurred vision for distance, near, or intermediate, and distortion of images and tilting of images, or ghosting, or a kind of double vision is also very common. Some patients, especially with anisometropia, they might complain of image size disparities, distance judgment errors. Sometimes patient may complain that I have been tripping frequently, I'm not able to walk down the stairs. So this depth perception may be impaired. And mechanical things are little lighter. There could be tightness behind the ears or nose, and usually while reading it slides down the nose, and the lens appears too thick, and rainbow effect at the periphery, some scratches, and the expectations were different. All these are patients' possible complaints. So first of all, in the investigation, whose wrong is it? So we have different parties in this task. Is it from the refractionist? Is it from your optician? Is it the patient itself? Or is it because of some issues inherent to the lenses? So these possibilities of error are with all of these people. Optometrists can have incorrect refraction, or incorrect prescription, or incorrect transcription of the details, and there could be a failure to identify and adjust for the facial anomalies. Sometimes, as Sir told, there could be a failure to include the vertex distance, and incorrect advice regarding the choice of lenses. From the optician part, again, incorrect transcription does happen sometimes, and wrong positioning of the optical centers, that axis marking, if it is wrong, this is going to trouble the patient. And wrong conversions, error in placement of segments, and failure to advise patients regarding suitable frames. So in some patients also, like Sir told, if you have a new presbyope and he needs a progressive glasses, but he wants a very small frame, you are going to have problem with this patient. So you have to advise the patient regarding the choice of frames. Some patients may have really very unrealistic expectations, like the glasses are going to solve all their problems. Usually these patients suffer a lot, and different patients have different tolerance thresholds. So that is also one issue. And there is something called buyer's remorse. Once you go and get a spectacle, you buy a 25,000, 30,000 spectacle because the salesman was very efficient. And once you go home the next day, when you see the spectacle, you feel, oh, that kind of thing will be there. Most of us also have that. So this will create some buyer's remorse, and then they might say that it is because of the problem with the spectacles. And very rarely you have patients who are feigning difficulties for refund. And what are the issues inherent to lenses? So base curve or lens thickness changes sometimes pose a problem, anisometropia, and when you use progressive addition lenses, there could be a distortion of peripheral vision and small reading area. That is a problem which is inherent to the lens, but it will cause a problem for the patient also. So most important thing in troubleshooting this patient is adequate history. This patient has bought glasses from you, he has trusted you, but he has problems and he wants to discuss it with you. See it in that perspective. Don't think that he is coming to trouble you, and be patient and help him to vent out his problems, and don't be defensive. Please listen to them. As humans, we all need that, and that is the greatest reassurance I think we can give a patient with problem also. So we could ask questions like, what are the symptoms present, whether it was seen immediately or after some time, is it better now, or is it with distance vision, near vision, or all the positions of gaze. So all these questions can be asked to the patient, and spend some time with the patient. It is worth it. And then you could do a workup, measuring visual acuity. So in this case, you have to try, if the patient has an old glass, always use the other glass and the new glass for comparison. You could very well tell them that, see, your vision is better with the new glass. Do you agree to that? Yeah. Okay. That kind of interactions should be encouraged, and check for the optical markings, whether the segment height is okay, and IPD, what we have. Sometimes there could be errors in all that. And sometimes repeat cycloplegic refraction may also be needed. And this one picture, so you have to have the optimal reading position of each eye. Not many people read at 33 centimeters. Sometimes it is more receding. So however the patient is habitually using the spectacles, always ask the patient to hold the near vision chart at that position, because that may be the favorable position for them. Actually, you can measure it. This is a very simple tape, and in needed cases you have to measure the vertex distance also, and look for the alignment and fit. If you are using a spectacle like this, it is very difficult to get the usual benefit from using the spectacles. And in case of patients with strabismus, again marking becomes a problem, and all these facial asymmetry cases, and like sir told, 4-point touch is also important. Also diabetes, we sometimes tend to overlook that. Always ask the diabetic status of the patient before giving the spectacles. So all these Malayali old gentlemen and ladies are reading newspaper, but when you look at them, you can see that their distance is very different. So all this will have this, these are their habitual distances. You are giving a customized spectacle. You don't give a blanket distance for them. So this should be borne in mind. And if you have a patient with troubleshooting in your office, take some time and make the patient read the print or computer, and let's sort the problem in that way. And posture correction is also important. And if you have a small lesser degree of cataract, lighting is also very important in solving this. And occupation, we all know all these carpenters, goldsmiths, and tailors, they have different viewing distances. Even with knowledge workers, IT professionals also, we do have this. We have to attend to this occupation also. So there are some special situations. See, mostly a patient with new cylinder, they will find it difficult to adjust to the cylinder. Everything is very slanted, curved. It will be a very problem for this patient. And sometimes a newly corrected hypermetrop. Me myself is a hypermetrop. So what happens, I'm very empathetic to the hypermetrops. Can I take 2 more minutes? So when you wear a new hypermetropic correction, your distance vision will be blurred. And so this has to be told to the patients. Initially, your distance will be blurred, but it will adjust on its own. Take some time and explain this to the patient. And then when you get a hypermetropic glasses, please tell them, use them constantly. It is not for while you're reading or looking at the computer screen, because your accommodation has to be, we are manipulating on your accommodation in this correction. And high myopes with presbyopic correction, again, they will have a problem. Usually, they prefer to read without spectacles for some time. But again, when they shift to the presbyopic glasses, they usually have problems. And some patients, bifocal users shifting to progressives, we all have had those patients. And there are now a newer kind of, relatively newer kind of spectacles called no-line bifocals, which is a modified kind of bifocal, but the line will not be there. And in patients who insist on separate spectacles for distance and vision, don't argue with them, just give them what they need. So they'll be usually happy with that. Giving PILs in these patients, they might buy from you, but it might be a problem for you later. And some special situations, like some people who are wearing glasses for same glasses for long periods. This may be a 6/12 vision, but he has been using it for past 8 years. When you give a new glass with 6/6, but they might find it difficult to adjust, because their adjustment for long periods is going to trouble us also. So the take-home messages, we can have technical problems, adaptational problems, and psychological problems in spectacles. If there is a technical problem, it's a no compromise situation, because the patient has come to you for a service, and you have given a service which he couldn't use. So take responsibility. Maybe sometimes you will have to replace the glasses. And next thing which you should do is you make a investigation, CBI investigation in that sense. What went wrong? You talk with your team, because how to refine your protocols, how not to repeat it. That is very important. That is something which I have learned from my personal experience. And adaptational things, you have to give an evidence-based communication. Evidence by me, I don't mean literature. You have to talk with the patient. You have to tell the patient, see, this is your old glasses. This is your new glasses. How do you feel with this? And after spending some time, patient should tell you, yes, doctor, I feel very happy with the, I can see better with the new glasses. I agree to that. Then we can talk to them that, but you need to adjust. It will take some time. Such kind of evidence-based communication would really help. And in some buyer's remorse and all, you reassure them, but it usually settles. And don't see these patients as the pain in the neck, because once the patient has bought something from you, he feels that he has a bad experience, but he's coming back to you. That is an opportunity, because most of the patients, when they have a problem, if they go to somebody else, you will not be able to understand your problems or to solve the problem. So see it as an opportunity and overcome your own prejudice. We all feel that he's troubling me for unnecessary things. But he has a problem, that is why he's coming. Don't try to discount that problem, and listen to the patient and basically believe in the patient. Nobody will come driving a car or coming in a bus just because he want to scratch you. They have a problem, that is why he is coming. However small the problem is, try to be with the patient and be her problem solver. And we all have a good relationship between the doctors and patients. So if you are solving this problem, actually you are making that patient your trusted ally. He will come with his relatives or his family members, because see, I got a spectacle from there was a problem, it was replaced, it was corrected, and that gives you more confidence in the establishment and win back the patient. And replacement and refund policies that you have to decide for each institution. And this is a very important thing, do not charge for the visit. Some patient, after buying their spectacle, they have come with a problem, and you are getting again 300 rupees from them. It doesn't look nice. And so this sometimes we'll not be able to understand. This will be done at the reception. So make a point to refund if you have the authority to do that. And instructions on the prescription usually we give, but ask them to read through that, adaptation issues. And they say that 70% of unhappy customers whose problems are resolved are willing to shop with the same business again. So let's remember this, and thank you. So I'll be leaving for another talk in another hall. If you have some questions, I'll be happy to take. Yeah. Okay. Mm. That seems very unusual to me. So did the patient come back after a few days after prescribing the spectacles? Did you check the blood sugars then? I think usually what I was seeing is when you have a myopic shift, when the blood sugars are at least more than 300 or something. Beyond 250 and all, usually we don't have a change. And HbA1c, we are looking for the 3 months control. And what is important for us is the immediate control, which is reflected in your FBS and PPBS. So probably I think that patient may have he might be having a high blood sugar when he came to you for the second time. And for near vision ads and all, you don't need to look for blood sugar actually. It won't affect. You think of the mechanism, what happens. So if there are no questions, thank you.
Thank you very much, Dr. Sanita. Very difficult topic, something we all dread, but she's explained how to go about it. Thank you. Our next talk is by Dr. Anjana Nair, and she's going to speak about refraction in special situations. Over to Anjana.
Thank you, sir. I would like to thank Scientific Committee KSOS for giving me this opportunity. I would also like to thank Dr. Sanita, Dr. Arun, Mrs. Ruxana, and Dr. Ruxana and Mrs. Rosmary for joining the session. Let's start. So I'll be dealing with refraction in special situations. So I'll be going through all these headings. So basically, pediatric refraction has been dealt in detail by Dr. Ruxana, so I'm not going to go into the nooks and corners of this topic. So one point I would like to suggest is, if in all possible situations, it will be ideal to do a dry retinoscopy, which is followed by wet retinoscopy, to have an idea about this accommodative efforts. These kids will have strong accommodation. So a dry retinoscopy in all possible situations should be done. So we all know that pediatric refraction is difficult. So in special kids, it's even more difficult. So who are these special kids? So with the special kids, I mean kids with neurodevelopmental delays or autistic spectrum disorders, or these kids. So they have a very high proportion of refractive error when compared to a normal population of children. So two things has to be stressed while we are screening the special kids. One is vision screening. So we all know that children are very fussy and very unattentive in our clinics. So it would be ideal if the optometrist can visit the home centers or home or the special kids, so that they will have more cooperation. They will be more familiar with the setting, and also their teachers or the caregivers will be present with them. So they also help us to achieve more attention or more cooperation from these kids. And the second point I would like to make is choose a suitable chart for vision assessment. And studies have shown that children with autistic spectrum disorders had effective communication with picture color chart. So these 2 points has to be kept in mind while we are dealing with a special kid. Squint and refraction, we all know it is so much of interrelated, and any cases of squint you should screen for any refractive errors. And actually it is more significant association with squint and refractive error rather than the family history of a squint. So we have to do cycloplegic refraction. Cyclopentolate is the standard of choice. CTC regimen is followed everywhere. It is almost comparable with a tropin 1% regimen. And in special kids, it is preferable to use a homotropin, since cyclopentolate will have such risk of seizures or some neurological difficulties. So in accommodative esotropy, the average cycloplegic refraction could be around plus 4.75. So whenever we are giving a spectacle to a kid with accommodative esotropia, we need to stress some points to these parents. One is, they have to wear the glasses for full time. So if they are wearing the glasses only for part time, the accommodation will not be fully relaxed. So when the accommodation is not fully relaxed, the child's vision will get blurry and the eyes will go into esotropia again. And the second point is, once they have started wearing the glasses and they are stopping it in between, the child esotropia might increase in the due course. So this has to be stressed to the parents. In intermittent exotropia, there is actually loss of fusion for brief periods. So concave lenses will induce a convergence. So any refractive error should be corrected to improve the fusion of these kids. That is, even if it is a minor myopia, it needs correction because we are using a concave lens and it will induce the more fusion. And hypermetropia, if the patient is asymptomatic, it need not be corrected. But in any hypermetropia with reduced vision, it has to be fully corrected, even though it is corrected with the convex lenses. And in children with esotropia, if the esotropia is more for near, we should consider checking AC by ratio. We all know that the normal AC by ratio is 5:1. In children with high AC by ratio, it cannot be corrected with the normal glasses. It has to be given like an executive bifocal with plus 2.5 to plus 3 diopters, or a flat topped D bifocal is another alternative to executive bifocal. Progressive myopia. What happens in progressive myopia? So there is a weak accommodation. There's an accommodative lag in patients with myopia. So whenever there is an accommodative lag, so there is a retinal defocus for a near object. So when the retinal defocus is there, it will act like a stimulus for eyeball growth. So again the myopia will increase. So it will go in like a circle. These are studies and postulates. So in order to reduce this retinal defocus for near objects, a progressive lens is preferred, and it will give a clear image at all distances. So another scenario is children after cataract surgery, bilateral cataract surgery, and there are two options as we all know. One is aphakic glasses for bilateral aphakias, and second thing is contact lenses. Aphakic glasses, so basically for every kid after bilateral cataract surgery, you you do have to go for a dilated retinoscopy. But here cycloplegia is not required as there is no lens. And since the kids' activities are more in the near activities, so you after reducing the working distance, you add a +2 to +3 diopters perical for the near activities. And as the child grows, you reduce the you also add the distance correction to these classes. And by the age of 1.5 to 2, it has to be changed to a executive bifocal. So what is the difference in contact lenses? Contact lenses after bilateral cataract surgery is again very useful thing. But here the contact lens of choice is extended wear contact lens. The material is a soft silicon hydrogel material. So the centration is very significant for these kids. And so itself the diameter and the base curve all can be customized in this contact lenses. And the power is calculated to each child's working distance. For example, if the child is a very young kid, the most of the activities will be near activities. So you calculate you do a refraction, a dilated refraction for distance and near vision, correct it along, and then you give a single contact lenses for that. So, but the child is slightly grown up, school growing kid it is. So then you have to, what you can do is, you do this retinoscopy, you correct it for the distant vision, and then you give a single monofocal lens for the studies whenever they are attending the schools for studies purpose. Like the two options are there. And for every kid, you have to give a thorough parent counseling regarding the complications of use of these contact lenses, and regular assessment and modifications is required as the child's eyeball growth or axial length, everything is changing. So refraction will change. Presbyopia, again another situation we all encounter in our day-to-day practice. So in presbyopia, we all know the accommodation is slightly on the lower edge. So we have to bring back the patient's near point to their useful working distance. So for the comfort of the patient, 1/3 of the accommodation has to be kept in the reserve. And most comfortable spectacle has to be prescribed rather than the clearest spectacle. Each eye has to be tested individually. And it has to be given, the power has to be described not by the age of the patient, but it has to be corrected to their activities. So each patient's activities will be different. And it is always better to undercorrect than to overcorrect for the most comfortable situation of the patient. Adults with small amount of hypermetropia, they might not come with a defective vision per se. They will come to you with a headache. So any patient with a constant headache, do a dilated refraction, and even if it is a small amount of hypermetropia, correct it. And counseling is very important because we know that they will not have a defective vision per se. They have this headache. So as and when they are using this new spectacles, their vision will be blurry. So we have to advise them that this is for your accommodation to get relaxed, and you have to wait for a few days to get your eyes adjusted with this accommodation and the new pair of glasses. And in pre-presbyopic age, this is again another practical scenario. So if the patient is having constant near work, even if it is a small amount of hypermetropia present in that patient, you give the glass correction, ask them to wear it for a constant use, the near work will be better. And if it is a more demands at workplace, say it's a pharmacist, they say they need to see the small letters on the ampules or microscopes once you are using the microscope. And so if it is a minor amount of astigmatism, you have to correct. And then in such patients, you have to give a small addition of +0.75 for near work as a progressive lens. And last but not the least, a role of dynamic retinoscopy is again important. Whenever the patient is having 6/6 vision, but they are complaining of headache or eye strain, you do a dynamic retinoscopy. This is a picture of MEM method of dynamic retinoscopy being done. The normal value of dynamic retinoscopy is +0.5 to +0.75. If it is more than that, it indicates a lag of accommodation, and so you have to correct it accordingly and then prescribe a plus correction for that. Thank you so much.
Thank you very much, Dr. Anjana, for the difficult topic and also the fantastic slides. I think it really helps to have an IT spouse who can help you with the slides. Thank you. Going on to the last talk of the session.
So I welcome Ms. Rosemary C. Anthony for the topic, use of prisms in spectacles and low vision aids.
Good morning, one and all. Myself, Rosemary. Is it audible? Yes. Today, I'll be speaking about use of prisms in spectacles and as low vision aids. In ophthalmology practice, we use prisms both for diagnostic as well as therapeutic for purposes. Here, I'll be discussing only about the therapeutic applications of prisms. So it can be used in variety of scenarios like correcting heterophoria, diplopia, and nystagmus, and as low vision aids. So when do we think of prescribing prisms? So we can think of prisms when the patient presents with asthenopic symptoms, and when you make an assessment, you find that patient has a binocular dysfunction. In such scenarios, you can think of prescribing relieving prisms for correcting the misalignment. So before prescribing prisms, you have to make two clinical measurements. One is the magnitude of heterophoria or the amount of deviation, and you should look for the fusional vergence reserve of the patient. Fusional vergence reserve gives you an idea of the ability of your vergence mechanism to adapt to this misalignment. So after making the assessment, the least prism which is required to relieve the patient's symptoms can be prescribed. And you should perform a prism adaptation test prior to prescription, and a phoria greater than 10 prism has to be referred to a surgeon. Then how do you do a prism adaptation test? Now you should have obtained a prior measurement of the associated phoria. Then you place prism in the appropriate base direction in the trial frame. Then reassess the phoria and give the patient an adaptation time of 10 to 15 minutes. After adaptation time, you again make an assessment of the heterophoria, and if the value measured after the adaptation time is same as that prior to the adaptation, that indicates that patient has a strong vergence adaptation, and this patient is not going to be benefited from prism glasses. So in such cases where prism adaptation is positive, you needn't give prisms in spectacles. There are various techniques by which you can incorporate prismatic effect. If the patient is wearing a refractive correction, then a simple and if your prism demand is very low, a simple decentration of your refractive lens can give the desired prismatic correction, or you can give it as ground down prisms. Lens will be a bit thick towards the edges of the towards the base of the prism. That's a cosmetic disadvantage while giving a ground down prisms, but each eye can tolerate a prism diopter of 6 diopters. And in case of high prism powers, Fresnel prisms are the option. So once you prescribe, you should mention the prism power in prism diopters with the base direction specified. And you can give both horizontal and vertical prisms individually, or in case if both elements are present, you can give it as a oblique prism. The power of the resultant prism and the direction of the base direction can be calculated using the simple Pythagoras theorem. Here in this case, you can see right eye has a +4 with 8 prism and left eye is +2. So when you give this as a prism, what happens is right eye becomes thicker. So it may not be cosmetically very good. So in such situations, you can think of splitting prisms. So while horizontally splitting prism, you can split the 8 prism into 4 and 4. So if it is horizontal, same base direction will be additive in function, whereas opposite base direction will be subtractive in function. But in case of vertical splitting, it will be vice versa. Now coming to Fresnel prism. Fresnel prism has the advantage of it being very thin, and you have it in a wide range of powers ranging from 0.5 to 30. It can be used in nystagmus, in stroke patients, in hemianopia, etc. So while fitting the prism, you should decide upon the power of the prism and base direction. Then you cut the Fresnel prism to decide size and shape of your carrier lens or the spectacle lens, and the plane surface of the prism has to be attached to the inner surface of the spectacle. While doing it, you have to submerge the spectacle lens and the prism in lukewarm water to avoid air bubble being trapped between the two. Now we will come to clinical conditions where prisms are applied. In small heterophorias, we can give it as relieving prism to reduce the vergence demand. In exophoria, we give it as base in, and esophoria base out. Prior to giving relieving prisms, you can try exercises to improve the patient's vergence demand using prisms in office. Then in nystagmus, In order to correct abnormal head posture, you can give prisms so that the null point can be shifted to the primary position. But the power requirement for prism would be pretty high and the patient may not be able to tolerate. Anyway, prisms can be used for diagnostic trial prior to surgery. In bedridden patients, vertically yoked prisms can be used, or they are called as recumbent prisms, to help them read in their supine position. In rehabilitation of stroke patients or CV, in case of CVA, you can use horizontally yoked prism. Patient may have visual neglect or visual inattention to the affected side, so their posture may be affected. Giving horizontally yoked prism may help to correct their posture and midline shift. In children with autism or with attention difficulties, children may present with toe walking, hand flapping, etc. In such cases, vertically yoked prisms would be helpful to improve their posture, gait, etc. and it enhances their attention and engagement. And homonymous hemianopia is a scenario where prisms are used as field expanders, where your base direction of the prism should be towards the affected side or the non-seeing side. Here in the first picture is a left homonymous aniopia. In the second picture, the patient views through the prism, so the field of view has been expanded towards the left. But prescribing prisms are also associated with many problems. Here in the first picture, you can see it is the prism-free view of the patient where a scene is perceived, and the right side you can see it's evident that left side of the field of view has been expanded with prisms. You can see the rear part of the red car and an extra door is seen. But you can also notice that on the right side picture, the front portion of the red car is missing. That is due to the apical scotoma. And here you have a picture of the patient with the left homonymous hemianopia, where can you see the red cross in the first picture? So when a patient is fixing at the red cross, then he can see the right side of his visual field, but the left side is missing. Now he is wearing a prism. So in the next picture, you can see his fixation is shifted slightly towards left. So his left eye views to the prismatic portion. So he can see his field of view has been expanded and he can see a person standing towards his left. But you can see that the right arm of that person is missing. That corresponds to the apical scotoma. Now in the third picture, he makes a scanning movement slightly again towards the left. So both eyes are viewing through the prismatic portion. So he can see two images. This causes diplopia and confusion. So these aspects has to be explained to the patient, or you should give him adequate training so that he get used to this new spatial orientation. Otherwise, he may find it difficult to move around. So solution to some extent to this problem is prism multiplexing, where you use Elie-Pelly lenses. Elie-Pelly lenses are simply sectoral prisms which are placed superiorly and inferiorly on a carrier lens. So what happens is the central area is prism free and patient can have binocular single vision, whereas superior and inferior portion can be used for field expansion. So training with prisms is very important before dispensing. 20 minutes per day activities for 4 to 6 weeks is recommended for the patient to get adapted to prisms. So peripheral prisms are often a mobility device. Patient may have problems with reading activities and near vision tasks when they are wearing an inferior sector prisms. So in such cases, you can use prisms as clips on. So it can be attached to the patient's refractive correction whenever required. On reading, they can remove the clip on. It is easy to get. And Pelly lens have a SLAM technology clip-ons, that is single lens attached by magnets. Can I go on? Yeah, okay. So homonymous hemianopia. Two main aspects that the patient complained us. One is colliding with obstacles or colliding with other pedestrians, and a wider field of expansion is very required in such situations. But our Fresnel prisms gives a maximum of 30-degree field of view expansion. The maximum power of Fresnel prism can provide 30 prism of field of view expansion, but that is not enough to avoid collision. Study says that you need to have a 45 degree of field of view expansion to avoid collision. So, future of prisms is multi-periscopic prisms, which consist of a cascade of half penta prisms. It is used in binoculars usually. It provides a 45-degree shift, and it makes use of the principle of double reflection rather than refraction in our regular prisms. So, adapting to prisms is often disorienting to patients initially, but training is very crucial to avoid trips and falls. Thank you.
Thank you. Thank you, Mrs. Rosemary. The sessions are over and the session is open for discussion. Any questions?
I can identify with Dr. Anjana was speaking about pre-presbyopic age group, because my wife, she's a dentist, and I prescribed her presbyopic glasses 37. She did protest for some time because she couldn't see the root to see root canal to do root canal treatment. So that is something we have to identify.
Yes. Okay, so let's conclude the session. Thank you everyone for your kind attention and the questions. Thank you so much.